to our speakers. We now have about 10 minutes for questions, so please go ahead and come up to the microphones, and I think we'll go ahead and start with Tim. I don't think your mic is on, Tim.
He says it is on. There we go. Tim Jones, Tennessee. Thank you both. Those are very different talks, but both of you discussed a whole lot of sort of psychosocial, economic, cultural, deep-seated issues that I think are big challenges. So if a budding young epi who is still idealistic came to you and said, I want to save the world, what's the one thing, where should I go and what should I do? What would you say to them?
You're the academic. Do you want to go first? And that'll buy me a little time.
A lot of people absolutely hate their jobs. They get up in the morning and they go to work and they don't know why they're going to work. They don't know what the point is of whatever it might be that is their little niche in society. They don't have a passion for their work. And I think we're privileged, many of us in public health, by not going to bed at night saying, why do I do what I do? We know why we're doing what we do. And we have a sense of mission, and we have a sense of responsibility for the public safety and health. So I think that's a reminder when you're up against the grind of state or local budget cuts, when you feel like you're more of a paper pusher than an epidemiologic activist. I do think we have to figure out how to work more efficiently and smarter. And I always think of a CSTE type organization as an opportunity to do a lot more sharing than we do. I mean, if we have a hepatitis C protocol for linkage to care that's working pretty well in the state of Nebraska, and you say, well, yeah, that's Nebraska, they don't have that many cases, I'm in New York, I've got a lot more cases, that's not applicable to me. Well, why can't we share that protocol? Maybe it's more applicable than you might think. More sharing, a more vibrant website, documents sharing, so we don't have to reinvent the wheel all the time. I think that's the kind of thinking that you have to do when you're up against a deteriorating work environment. You have to figure out how to work smarter. What we're trying to do in academia, we're up against trying to do our research with our grants. Vanderbilt has to beat Harvard, Stanford, Hopkins, UCSF, Washington, every single grant we go up against. And we have to operationalize our work effort to be smarter than they are and more effective and more efficient than they are. Otherwise, we go out of business. So I think those sorts of sharing opportunities where each of us is helping write each other's grant, I think that's one way to get out from under the beleaguerment that a lot of us are feeling in this environment. We've got to work smarter and we've got to work more collaboratively.
And I'll just add to that, I think part of working smarter is training and thinking in terms of being a 21st century public health professional. When we look at the public health gains in the 20th century, they were very focused, they were very technological. Dramatic declines in vaccine-preventable diseases, the eradication of smallpox through what was really 19th century technology, but primarily surveillance and vaccination, fluoridation of water, control of blood pressure. These were all technological fixes. They were very focused, and that's what was required to address those problems. Some of the challenges we face today require a different approach. And for instance, when we look at some of the major causes of death, and we'll specifically talk about the Alaska Native population, for instance, our leading cause of premature death is unintentional injury. Second leading cause is suicide. Boy, I wish I had a vaccine against suicide. But it's not like smallpox, where you have a chain of causation, a chain of transmission, where you can interrupt at several points in that chain. It's more of a web of causation. And that web includes not just suicide, but also a number of sexually transmitted infections, bloodborne infections, when you start talking about injection drug use. And it takes a much bigger picture that begins to incorporate not just microbiology and the stuff that, to be honest, I really love, but also behavioral health and a real systems understanding of how things work.
Hi, my name's Dan Church from the Massachusetts Department of Public Health. And first of all, I just want to thank both presenters. They were both excellent presentations. And I wanted to comment on the hepatitis C presentation, which was incredibly thorough. It was excellent. But I wanted to expand on your comments about the increase of incidence of hepatitis C infection among young people who inject drugs. Because as you mentioned, in Massachusetts, we've seen a really large increase of hepatitis C infection in that population, but it is continuing to really explode. And we are currently getting over 2,100 cases of hepatitis C reported to us, new reports of hepatitis C infection with people under the age of 30 every year. I mean, that's a huge number of people in one state. And there's no reason to expect that this is limited to Massachusetts. We just happen to have reasonably adequate surveillance for hepatitis C. Most states don't. CDC only funds 7 jurisdictions to conduct surveillance. And they were talking yesterday about reducing that number down to 3. So I think we really need to ramp up what we're doing for surveillance for hepatitis C, particularly for this population of young drug users. With what we're seeing with opiate addiction and overdose throughout the country, we really need to better measure this and respond to it. And I don't think we have a lot of time. I think we need to move on this as quickly as possible.
There's nothing I can add to that. That was excellent. Other than maybe to repeat a point I was making earlier about we've got to somehow be able to address the upstream issues of why people begin to inject in the first place.
Okay, and we have just a couple of minutes before 10 o'clock. So what we're going to do is we have 2 more questioners. So if folks need to leave, it's almost 10 o'clock, feel free to do so, but we'll go ahead and address the next 2 questioners.
Quick question for Dr. Vermund. You mentioned climate change a couple of times in your presentation. When I raised this issue at our strategic plan meeting at our State Department, and I'm from Arkansas, I was met with kind of blank stares, and we went on to discuss tobacco and obesity and other things. How do we raise this up as an issue for our leadership? But more importantly, what are the specific agenda items that epidemiologists should be tracking to begin to engage this issue?
We may be assisted by Mother Nature. There's no question that the warming of the southeast of the United States, for example, is nurturing the looming threat of dengue, and we're already seeing substantial expansion of chikungunya, possibly unrelated to climate change per se. It's sort of like a West Nile phenomenon where it gets introduced and we have the conditions to expand. But I do think some of the elegant science that we're seeing coming out of some of the GIS and climatology modelers can be empowering for us, because some of these predictions may be able to hit home. We may be able to demonstrate in local venues, be it Arkansas, Tennessee, wherever, that we are going to predictably increase arboviral transmission, for example. And if we can make that link of climate change to a discrete public health challenge, and we can do that with some degree of scientific gravitas, I think we are in a much better position to argue the case.
Hi there, this is Aidan Veron from County of San Diego. First of all, thank you to both the presenters for really detailed and fascinating presentations. This is a question primarily for Dr. Butler regarding hepatitis C. So you mentioned about correctional populations having obviously a very elevated prevalence of hepatitis C, and you also discussed about interventions, and you talked a little bit about cure, but not so much in the framework of cure as an intervention, particularly given the cost burden for all US citizens in terms of doing population-level treatment. When I was doing my formal work with Emory University, we were certainly pushing for the consideration of specific treatment among correctional populations to address that elevated prevalence burden. But one of the system challenges I think a lot of us face is about the difficulty politically with preferential treatment of injection drug users or correctional populations. even though they may have the most elevated prevalence and the highest risk factors. So from both of you, what is your take-home message, or what is your strategy for dealing with the system-level issue of the need for potential preferential treatment among politically unfavorable populations?
Yeah, what a great question. When I talk about the fatalism I observe among my full-time clinical colleagues, that's probably manifest most among actually some friends who are providers in the prison system. They know the health impact. They also know the political reality of the healthcare financing. It's going to require a lot of work that I think many people in this room are well equipped to do in terms of working with policymakers to understand the situation, that it's not a matter of favorable treatment, it's just a matter of fair treatment. And where I would start with that is posing the question of, well, let's start with a specific example of, say, prisoner A. If prisoner A wasn't in prison, would he qualify if he had health insurance through his work, or if he was still unable to find work, he qualified for a publicly funded support? Would he be getting treated if he wasn't in prison? That's where I think we begin to open the door. Right now, it seems to be the assumption is, well, they did it to themselves, and they're in prison because they're bad people, and we don't owe them anything. And that's a very inhuman approach. I hope everybody, if you ever have a chance to visit someone in jail or prison, that you do so. It's always a little disturbing when you run into them in the Magic Mark down the street. But there's things in prison that you learn that you would never imagine goes on. And there's, of course, intravenous drug use, there's tattooing. So those transmission factors continue in prison.
Just briefly, in 1999, the global pharmaceutical industry charged $12,000 per patient per year for antiretroviral therapy. And the Indian generic pharmaceutical industry thought they could make money by charging a lot less. And the entire PEPFAR program is now based on Indian generics. And that forced the global pharmaceutical industry to make less money and charge $900 per person per year, giving you some sense of that grotesque profit margin. And the Indian pharmaceutical industry can make money with $130 per person per year. So $130 per person per year compared to $12,000 per person per year. We're in the same situation in 2014. Gilead has this opportunity to make an unbelievable amount of money, and they think that the proper corporate strategy is to charge $1,000 per pill. And I do think it's incumbent on the public health community to work with the FDA, work with the kind of solution that we had for the HIV drugs, which was that the Indian pharmaceutical companies were allowed to produce and market based on national emergency. You remember when George W. Bush was president, and I think at the time we had 3 deaths from anthrax in the 9/11, post 9/11, in that October, the month after 9/11. And he then got on television and declared that it was a national emergency and they were going to suspend the obligations to Bayer Company. They couldn't produce enough Cipro, and they were going to buy generic Cipro even though it was against the national. For our country, 3 deaths was a national emergency. Meanwhile, the global hepatitis C epidemic, we're expected to pay $1,000 a pill. So I think the pharmaceutical companies have done this to themselves. They are changing the rules with extremely unreasonable and unfavorable pricing structures and a level of greed that is absolutely breathtaking. So they are forcing the global community to respond in a public health emergency capacity rather than simply saying, okay, we're going to pay $1,000 a pill.
Joe, can I just add to what Jay was saying? The fastest way out of jail in Tennessee is to get diagnosed with hepatitis C. because the sheriff doesn't want to have responsibility for the cost of treating.
I'll remember that if I have trouble going to the airport.
Well, thanks again so much to our plenary speakers.
Really enjoyed the talk. Really.
And as a token of our appreciation, we're going to give each of them a copy of Deadly Outbreaks. And for those of you who haven't read the book yet, I encourage you to do so. And Dr. Butler is actually one of the featured epidemiologists in here. So thanks again.